Thank you very much, Dr. Lee. Thank you very much, Dr. Lee. I think this was really impressive to see the two insurance systems. And I also would like to greet the guests that came a little bit later on. And I think it's time now to open up for questions, especially for those who are interested to learn more from both systems. So who would like to have the first question?
Robert James Parsons, journalist based in Geneva. I've been here for 30 years. I'd like to ask Dr. Lee about dental care and eye care in Taiwan. In Switzerland, that doesn't exist. Unless one is having dental surgery, the insurance doesn't cover anything. Dentists, real dentist DDSs are very rare. The others are just trained technicians. I can tell you, myself and 4 friends at different times went to the University Dental Clinic for emergency work, and the only thing we were told was they'll pull our teeth. 2 of them went to France, I went to France, another one went to Taiwan, another went to Hungary in the end. But a friend of mine, a retired person from the ILO, had to have bridge work done. She had broken a tooth, 5,900 francs. 800, 900 francs for a cavity to be filled. And so we don't have real dental care. What do you offer? Also eye care. I have the basic insurance coverage. It pays 100 francs every 3 years for eyeglasses. And so perhaps Taiwan does better. Could you explain that to us?
Actually, I think this is a very good offer to Taiwan people, the dental care. Yeah. But dental care have a different field, yeah. And for general dental care, no problem. But for some time, for some processes, maybe you have to pay by yourself, yeah. So I think, but at least, I think for each people, even if you're toothache, yeah, sometimes it's more painful compared to have some other disease, yeah. So. But since this, I think for people, if we can cover them with the dental care, they will be happy. And so far, it's fine. But now many new technology for this care, yeah. But some of them are not really paid by the national health insurance. But we know in Taiwan now, if you want to be a dentist, for a medical student, they want to choose to be a dentist better than some other medical professional, yeah. Because it's sometimes I think the situation is a little different, yeah. Minister, do you want to comment?
The second point was about eye care. So what is your insurance paying for eye care? Let's say glasses and contact lenses and so forth.
Yeah, also covered by our NHI. Yeah, I think basically, yeah, everything, even the drug, new drug. Yeah, we have a committee which are composed by the medical provider and the public. They will discuss whether they can enroll some new medication or some new technology. And I know since our NHI budget is just a global budget, so for some group, they don't want some new technology to be enrolled in this the national health insurance. But for the public, okay, they wish everything can be covered. Yeah. So this is just a balance. But I personally think that if we can control our finance well, I wish all the new drug, because the new drug means that it is a high technology, it is more powerful and more useful to our people who wish we can offer them such kind of new technology and new drug. Yeah. So for the eyes, ophthalmology is also the same. We try to cover everything. Yeah. Yeah. Please. Yeah.
the main question is how you put the limit for technical reason. For example, if you to think about robotic surgery, we know that in some place it's not very useful, it's just aesthetic reason. How do you put the limit in your committee?
We can say that actually this is just, this world budget is fixed. So you perform more medical performance than we say the cost of each point decrease. So it is just, for the medical professionals, they did more. However, maybe they can get more. Yeah. So this is the problem. But if we try to reduce some unnecessary medical performance, in that way, I do wish we have more budget to support this kind of treatment. Yeah. So your question is that because it actually sometimes we have that some new drug cannot enroll into our national health insurance. So some pharmaceutical company they also have some complaint, but we will always try to negotiate with our medical professionals. Yeah. And medical professionals, I think also some difference because as I mentioned that our system, we have medical center, we have the regional hospital, and we have private clinics. So different background have a different philosophy. For some doctors, they are working in the medical center, they do wish high technology can be applied for their patient. But for private clinics, maybe they are scared. For this high technology, we occupy a lot of budget.
May I have a question too? I'm curious about you mentioned about you are going to reform your health system, and you point out how you will transfer hospital-based to community-based services, and you also mentioned you will reinforcement of adequate case management. Would you mind share detail about what do you mean case management in your health system, and how do you pay under your health social insurance?
I will try a part of answer for the first part, and perhaps our specialist on tariffs in Switzerland can give other parts of answers. On the first part, a part of these efforts are cantonal, on the competence of the cantons. It means you have 26 different systems trying on different ways to you can take the example of palliative care. I was president of the Cancer League in my canton before the ministry. We introduced, partly with private money, ambulatory palliative care in the whole canton. We could prove that it's cheaper than have the same patients in the hospitals. More than 90% of the concerned people want to be at home. It's more efficient, but we have wrong incentives in our health system because we have not the same payers for hospitals. In the stationary system, we have about 50% paid by the state, 50% by the insurers, and in the ambulatory system we have normally 100% paid by the primes and by the insurers. So it gives wrong incentives to make more things in the stationary way than it's necessary. And we try to change this financial system with the wrong incentives, because it's very difficult because of political reasons. Normally, because if you are a payer, you don't want to pay more, and because we have different payers, each payer try to pay less to let the responsibility to the payer. So it was the reason why we started with private money, and then we could prove that it's more efficient to do it, and then more and more it's possible to have public money, but it comes from the canton system. So the canton pays with his own health budget, not by the insurance budget. He pays people paid from the hospital and from the cancer league going at home between nurses and teams with nurses and physicians organizing a whole system of treatment for palliative care, especially in oncology and in some other kind of radiology. It's one example. Because we have a very federal system, often the innovation doesn't come from the national system, but you have disadvantages to have a federal system because it's not coherent. You have sometimes very important differences in equity curations, but you have other side advantages. You can try some things on a very little area. If it works, all the cantons copies. If it doesn't work, okay, you stop it. And that's how we try currently to do it. You can try it probably in Taiwan if you in a top-down way. In Switzerland, it's nearly impossible or very difficult to do it in a top-down way because the payers are in the cantons. So if you try to decide in the Swiss Parliament to make talk about the program for the dementia strategy of Switzerland, we do it with some million of francs, means with nothing. But the idea is we give the cantons possibility to do things, to compare, and to have a system of benchmark and of good examples we can copy on the words. It's slower than a centralized system, but perhaps more creative because you can try original things in little areas.
Let me make it clear, because in Taiwan, our co-payment system, only for drug. For other, I say, some expensive drug or some test, we don't have co-payment system. How about in Swiss or in Western countries? Co-payment.
It depends how we count. You saw we have about 65% paid by the individually paid private paying in our system. From this 65%, you have about the half are primes. So the primes are paid directly by your individual money, with exceptions if you earn less. But for normal people, they paid it with each month or between 5 and 20% of the earn. And then the part, if you are treated, we have a system which defines that the first you have to pay 700 francs by your own, 10% at the beginning. No, excuse me, let me try. At the beginning, you have to pay a fixed amount. You can choose the fixed amount. If it's low, you pay more primes. If it's higher, you pay less primes. So people, young man with good health does pay less primes than women, elder women with bad health. So we have a little problem of equity in this question. What we see is that, for example, in Geneva we have the highest, because the costs are high in Geneva, people choose higher participations, pay less primes. And some economists say if you pay more, you consume less. If you see the Swiss statistics, it doesn't prove a direct correlation, but the cantons with the highest average participation of patients to the system are the cost-fullest cantons in Switzerland. So it's surely wrong to say that if you pay more, you cost less. this common sense idea to say, so if you have to pay more, you don't go to the physicians, you keep it home. Sometimes you do it, but sometimes you do it too long. So you wait too long time to go to the physicians, and then at least you cost more to the health system. We have no evidence to say that it's more efficient to ask people to pay more themselves to the system. It's more or less the contrary. Perhaps somebody doesn't approve here, but
in international comparison, the out-of-pocket pay for Swiss people is relatively high. We are almost highest in out-of-pocket pay in the OECD comparison, due to the fact that we have this premium system, and due to the fact that certain things like dental care is not covered at all. The out-of-pocket pay is relatively high among the OECD countries.
And the people here can accept such a complementary system.
They have to accept. There is no choice. So, like the colleague explained there, you accept. You are in the system, and well, you have about 30% of out-of-pocket pay for and this is high compared to other countries.
So we, Taiwan, we just follow the system from the way to Germany before. And what do you think? Maybe you cover French in Germany, your parents, yeah. So what do you think? Our Taiwan system, already, because we should have revised our system, but I'm not sure whether. What do you think?
It's difficult to compare if we take only the equity question. So we have surely more equity in the German system or in the French system than the Swiss system. We have, if we compare the Swiss system with a lot of other systems, we have good results in a lot of topics, but not in the topic of equity. And normally, in the international, if you compare Switzerland with other countries, in the international way, we are between rank 2, 3, or 10. It depends of the different indicators. But we are on rank 35, 40 in the questions of equity. It's directly related with the financial system. So we try regularly to change it. We have, as I said, for the lowest incomes, we have relatively good cover because the state pays the subsidies for the price. But you have in Switzerland between 200,000 and 300,000 people out of the system because they can't pay the price. Sometimes Swiss people, sometimes foreign people, illegal people in Switzerland. Officially, illegal people have to be covered by the insurance if they are here for more than 2 or 3 weeks. But often they are afraid to officialize their status, afraid to leave Switzerland if they announce themselves, so they keep in illegal situations without real insurance. That's one of the more difficult parts of Switzerland. I don't know how is immigration. We have a high part of immigration in Switzerland, and we have, for example, it's difficult to have statistics about illegal people in a country. We try in one country, in the western part of Switzerland, which is the capital of Vaud. We have all year about 2,000 young people, illegal young people in schools. So if you make an extrapolation to Switzerland, probably 200,000-300,000 people illegal in Switzerland. These people should be insured, normally are not. And then you have poor Swiss people, very poor Swiss people, are not covered by the system. Sometimes they have the subsidies to pay the price, but they use the subsidies to do something else, and then they are kicked out of the system. But we are still federalist here. In the eastern part of Switzerland, we have blacklists of people who are not insured. So if you go to a physician or to in the western part of Switzerland, we have no blacklists. We have all the systems to cover poor people. I have one question back. you talk about 93% of health professionals involved in the official health insurance system, and if I understood right, these people have to ensure a minimum of quality engagement. It's right. How do you measure it? What have they to do? We discuss currently in Switzerland about we have a mandatory system. Each physician can practice in the health mandatory health insurance system, and we discuss about saying in the future not each physician can do it. He can do it only if he agrees to participate to quality programs or such things. How do you do it to have your 93% with quality systems in your system? They individually sign contracts and with which content?
Yeah, especially for some, especially for 93% to have a contract with our NHI is reasonable, but for others, maybe most of them belong to the cosmetic. Yeah, cosmetic. It is. I mean, they want to patient. They go there. It's not in Taiwan. We say if you doing the cosmetic surgery, it's not a disease. It's not covered by our NHI. So for that kind, maybe they have to pay by themselves. Yeah, that's not covered by NHI insurance.
And the other point was how do you ensure the quality of the medical care? That was more the question, yeah.
Yeah, no problem, because we also have another system just to monitor our medical quality. And in our NHI, we also have, as I mentioned, the pay for performance. Yeah, it depends on its quality. Or we also have a routine checkup. But another
hospital accreditation.
Accreditation. We also, it is also belong to the non-profit system, and we monitor our medical quality in different hospitals, But actually, Taiwan, I think we frankly speaking, because Taiwan doctors, they are always very smart when they're in high school, So when they became the job, they always do their best to give the patient good medical care. So the quality, it depends on that. Just today, when I was in WHO, we care for antibiotic usage, for the infection control. These are also very important in the medical service. But we have that system to run to check it. Please.
Okay. Other question? Yeah.
Question.
Thank you for your very clear information about the Swiss health insurance system. My question is those like the prevention measure were covered by the healthcare insurance system? For example, like the vaccine or some measure to prevent some certain of disease.
Good luck, Bettina. Well, I tried shortly. We had a project of prevention law in the Swiss Parliament, I think 3 or 4 years ago. The Swiss Parliament said no, we don't need a law about prevention in Switzerland. It was a strange coalition between tobacco industry, wine producers and other interest groups which are selling their products in Switzerland from morning to evening, and between some insurers, it was a very strange coalition. But majorities the majority in the parliament decided not to want a specific law about prevention. It doesn't mean we don't do prevention, but it makes it very complicated. So we have cantonal competencies to do it. For example, I talked about the cancer league in my canton, but it's the same in 25 other cantons. We have a coalition between cancer league, different rheumatic league, other associations by diabetic league, and we have common structures to pay information jobs for young people, prevention programs, which are financed partly by taxes about tobacco products, which are re-affected for programs. They are paid partly from the cantons. So each canton can decide we pay more or less for prevention programs. I think more intelligent cantons pay more but the problem is you can pay more. And probably it is economically efficient, but the efficiency is not in the same year, in the same budget year, but it's perhaps 5, 10, 15 years later. And normally, I don't know how it is in Taiwan. In our country, you are finance minister perhaps for 5 or for 10 years, and you don't see the effect of money you use for prevention. So, if you compare what Switzerland uses for prevention in money, and you compare it with Germany, France, or other European countries, we expend probably perhaps 50% of countries around Switzerland. So not that good. So we have in this domain a big job to do.
Thank you very much. I think that if there are no other questions,
If I understood right, you had in the past you had more than one insurance in Taiwan, and now you have only one. What has changed with the fact that you have only one insurance? Is your quality better? Are your costs lower? Are your patients more satisfied of your presences? Or what has changed? Can you answer this question?
You mean, are people satisfied to our national health insurance?
What has changed with the fact that you have only one insurance instead of more in the past?
If I may, well, the answer is that over the change, the public does get satisfied, but the provider does not. So that is the big major difference between the one insurer and the multiple insurers. And I have to confess, actually, I am among the minority people that are for multiple insurers. But I'm going to fail anyway. In Taiwan, we have such high satisfaction rate. So it's which is kind of both good and bad. It's good that it's good for the politicians, but it's bad for any reform. Yeah. So maybe that's
because actually, as I mentioned, in the past 37 years, I'm a clinician. Yeah. So I work in the hospital and ever been the hospital manager as a superintendent there. So I know this background. I think we should reform our NHI administration operations because we cannot only force our medical professionals to do a lot of work. So as I mentioned, I found the top 20 medical laboratory tests. Actually, they spend a lot of money. However, I think for each national health system, even in the Swiss, I think the negotiation and the trust is very important because most of the doctors, they don't trust. They think if they do more, they can get a lot of money. But in another way, we perform too many medical performance and then we get less money. So it means we are working harder, but we get less money. This is not fair. Yeah. So I think the trust is very important. But for the last year, I do my best to communicate, to negotiate with our medical profession, and we try to find one way that we stop some unnecessary waste of the medical performance. In that way, we can control our point and then to get much money. So I think, as in the past, our NHI, we never get a survey whether our medical professional were they satisfied to our NHI. But since I became the Director General, I performed such a test. So there's just the director call said that actually our medical professionals, especially physicians, they are not really very satisfied to our NHI. However, they still think NHI should such persist in our Taiwan medical care system. Yeah. So I think maybe I wish at least 1 year later, I wish all people will be, including medical professionals, they will be happy to our NHI. Yeah, I do my best.
Sure. No perfect system anyway.
No, it does not exist. I turn around because I have people in my back. If there are any questions in my back or to my side and to my left. If this is not the case, I think it's my honor to say a great thank you. I think we have only been able to touch upon little points, learning that yes, you have a system where the patients are happy and the doctors would be also happy, but you are doing your best, as you said. We also touched upon the interesting point of prevention, and I think Dr. Wang was listening with interest about what is going on in prevention in Switzerland. Probably we would have a whole afternoon on prevention only. I really would like to thank both Dr. Shan, Dr. Li, Jean-François Steyer, all the people who made it to come. I hope that you had the possibility to learn and to see how it happens somewhere else. And I hope that this is only a start of a long discussion about how the ones and the others do their healthcare system. Thank you very much to everybody. Thank you to those who made their time. And I think that a lot of you will be around for further questions, but because we wanted to be somewhere in time, I'd like to close the meeting here with my deepest greetings to everybody and a good way home to those who have to leave. Thank you very much.